the picture for in Arizona. Good one. Next. Can you go back? Yeah. The one on the right. Today my topic of discussion is this article from Journal of Endovascular Therapy, which percutaneous endovascular aortic aneurysmal repair, a prospective evaluation of safety, efficiency and risk factors. This is a German article from two institutions, Department of Vascular Surgery from University Hospital, Münster, Germany, and the second one is from Department of Vascular Surgery, William Harvey Clinic, Germany. The purpose of this study was to evaluate the efficiency of totally percutaneous endovascular aneurysm repair in a large cohort of patients. Previously, there were studies with a smaller number of patients. In this study, the number of patients is little bit more. And to define risk factors for failure with a 10 French vascular closure system. The treatment option for AAA were surgical treatment on one extreme, and the next one is the traditional endovascular with cut downs. And now on the other extreme is the total percutaneous endovascular technique. The complications of cut down, well aware of, wound infections, lymphocyte hematomas more common, but the other factors like patient discomfort and also the other injuries like neuralgia due to damage to the femoral nerve and many. The previous contraindication which were in the previously done studies on this topic were obesity, calcification of CFA, scars in the groin, and learning curve of the interventionalist. And the closure device, they are usually available for 7 French to 10 French closure device. But now the pre-close technique is used in the study. How they are using? The method in the study is a prospective study, examined the feasibility and safety of percutaneous femoral artery closure with a single ProStar extra large 10 French vascular closure device. In this, they use the ProStar extra large single device applied in conjunction with the pre-close technique. The time duration was January 2004 and December 2005. So it was the total duration was 2 years. 535 total patients were enrolled and were treated for aortic aneurysmal disease during this period of time, and 35 patients were excluded. Next I will give you the exclusion criteria, and leaving 500 patients. In those 500 patients, 4 months 7 were men, and the age range was 72 years plus minus 6.6, and treated for aortic aneurysm using the Talent or Zenith stent graft delivered to the various sheaths. The sheaths like 14 French, 16 French, 18 French, 20 French, 22 and 24. And what was they were seeing in this patient was primary clinical success. They defined as the freedom from additional early or late procedures to treat any complication at the access site, commonly the femoral one. The data were analyzed to reveal any correlation of the access site complication or early or late repair to operator experience or risk factors. This factor they defined obesity, extensive femoral artery calcification, and the previous interventions and scars in the ground. These are the methods. But simplifying the exclusion criteria on which basis they excluded the 35 patients. The first one is the severe atherosclerosis of the CFA, so much severe that it required the reconstruction. The first criteria. The second one was aortomonoileal graft previously used, and CFA aneurysm, and previous FEMPOP bypass. On the basis of these 4 criteria, they excluded 35 patients. Now the patient population, total number of 535, excluded 35, men were 4 months 7, age range 72 plus minus. Look at a most important point which is different from other institutions. They are using spinal anesthesia mostly 90% of the cases. We are using mostly the general anesthesia, and the rest of the cases they used general anesthesia and the local anesthesia. And they given the nearly equal chance to the Talent graft and the Zenith graft. They used the Talent graft in 273 patients, which makes the 54.6%. And the other category, Zenith graft, 2 to 7, 45.4%. And how they followed these patients? They followed these patients duplex just after the procedure. Once finished the procedure, they went for the duplex. And the CT scan within 3 months and the yearly interval. The criteria of definition they defined, as I already told you, primary clinical success was defined as freedom from any additional early or late procedure, meaning successful closure. And and no complication at the SS sites. How they analyze the data? They use a statistical test which is beyond even our scope, Hosmer-Lemsha test, to determine the relationship between sheet size and complication. This is one significant thing why they use this test. And the second thing, cost proportional hazard model. But they determined that correlation between complications and early and late repair versus one category this thing versus obesity, CFA calcification and scar, previous groin scar and interventions and operator experience. All the other factors on the other side. So it makes the two categories and they use this model. And significant p-value, they used it less than 0.05. And the system with quite advanced one, they used SPSS 15 was used, because previously I have the experience of using only SPSS 10. I didn't know about this system. This was a picture of that pre-closure device. The technical details are different and how they put the sutures, and it's not very much clear, but we have to go with that. This is after the stitch is applied, and this is the knot, the slip knot. When they apply the stitches, they put this knot and they pull it up and it tightens. This is called Fisher's man's knot or true lover's knot. These are the two different colors of the thread. The result, the most important thing rather than the technical details. And primary success was achieved in 96.1% of all percutaneous approaches. 23 patients developed early, means 16, or late, which was 7. Complication at the SS vessel in 12 cases. Hemostasis was achieved using plagiates with the prostar sutures, which was already placed, and no wound complication were recorded. This is a very interesting thing. The need for early conversion to an open SS correlated with PFA calcification and operator experience. These are two important things, CFA calcification and operator experience. They were related. The risk of late SS site repair was significantly higher in the presence of groin scar. If the patient has previously groin scar, then the risk of late complication was more. Correlation between the sheet size and with the early conversion to open SS was very weak, but compared to all the factors. And obesity was not a risk factor. This is a very interesting thing. They use the bifurcated graft in 403 cases and tube grafts in 97 cases. That makes total intervention 903 in 500 patients. And primary clinical success was achieved in 868 percutaneous approaches, regardless of it may be in a single patient or more than one patient. 96.1%. The secondary procedure was done in 35 patients out of those 500 patients, and it was 3.9%. 35 interventions, not patients. 35 interventions out of total 903 interventions. And they were done due to insufficient hemostasis in 28 cases, false aneurysm in 4 patients, arterial thrombosis in 3 patients. And how they did it? The vascular exposure was done in 23 patients. And the second technique which they used, the prostar with plagiates, it was done in 12 patients. The timeline for this vascular procedure was 6 procedures were just done at the end of the procedure, 6 patients, and 4 after 24 hours, 2 after 2 days, and 1 after 4 days. Follow-up. No wound complication was recorded in these 35 interventions. And mean follow-up period was 28.5 plus minus 8 months. Quite a long period they followed it. Complications were found with the previous one. CFA calcification 37.8%, scars in the groin, means the previously which we see the complication. They were related to CFA calcification. It is not that calcification which is requiring reconstruction. It is just the calcification which is maybe in the anterior wall or partial calcification. And the other one is scar in the groin or the previous intervention in the groin. They were related to 23.8%. An inexperienced operator, the person who operates less than 30 procedures, and per year it is 14%. And statistical analysis. This is I cannot understand about the details of statistical analysis, but I am just giving the view. CFA calcification and operator experience. They found these two strong factors which were related to these complications. The other one, sheet size and scar in the groin, has weak, this is a spelling mistake, weak correlation to complications. False aneurysm one thing, and arterial thrombosis. These two complications, they were more recorded in the scarred groin. They were not in the other patients. Obesity was not a risk factor to any complication. This is very different from the other studies, which are studies like Singh et al. And many Howell et al. They described the obesity major factor in complication. But in this large cohort patients, there was not a risk factor related to this obesity. Discussion results are similar with other studies, except that obesity is not a risk factor. 11 years ago, same study with same device was done by this instrument, Arizona Heart Institute, by Dr. Dietrich, and closure of large percutaneous access site using the Prosper extra large percutaneous vascular surgery device, and they were still seeing the results, and it was nearly 12 patients which they presented in 1999 in the same journal, Journal of Cardiovascular. This is Journal of Cardiovascular Surgery. Sorry. And conclusion. My conclusion after this is percutaneous EVAR using the ProStar extra large state with minimal early and late complications. Operative experience is one of the most significant predictors of success. It is seen by our study. And anterior wall calcification and severe fibrosis of the SS wall, means the previous intervention and groin scarring, also the predictor of primary failure, whereas obesity and sheath size are not. That's all. This is the metro in Phoenix, means we are